So good morning. I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of December 18th, 2024 to order at 9:31 a.m. Pacific. Melissa, if you could please call the roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Robert Judge.
Present.
Chris Lehman.
Present.
John Murray.
Present.
Dan Kennedy.
Present.
We have a quorum.
Thank you, Melissa. I would like to now ask any board members if you have any declarations of real or perceived conflict of interest that you would like to provide to the board today. Please raise your hand if you would like to do so. So it looks like I see two hands raised. Mr. Judge, I believe yours was first. So Mr. Judge, you have the floor.
Thank you, Chair Bailey. Before we begin today's meeting, I want to state for the record that should any matter arise where I have a potential conflict of interest due to my relationship with my employer, Moda Health, I'll disclose the nature of that conflict and recuse myself from any related discussions and voting.
Okay, thank you, Mr. Judge, for your information. Next hand that was raised is Mr. John Murray. Mr. John Murray, you have the floor.
Thank you. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs, comprised of 3 independent pharmacies in Eastern Oregon. Pharmacy services contracted with the PBM's insurance company in the state of Oregon. Because using the language of the Ethics Commission, because the PDAB is an advisory board that simply provides information to others who have rulemaking authority guidance from the OJEC, it is that it appears that at most you would have a potential conflict of interest each time the PDAB meets. Thank you.
Mr. Murray, thank you for sharing the information. Let's see here. I would now like to ask any members here today if they have any changes to the draft minutes from the November 2024 meeting that you would like to present any changes to the minutes on. Mr. Judge, your hand is raised. You have the floor.
Thank you, Chair Bailey. Actually, before we get into that, I just wanted to inform the board that I have a conflict at 11:30 that I can't avoid, so I will be leaving the board meeting at 11:30 today.
Okay, thank you for making us aware of that, Mr. Judge. Let's see here. So moving forward related to any amendments or changes to the draft minutes from November 20th, does anyone have any feedback related to those minutes that you want to present today? Okay, with no additional comments related to the minutes, I would like to ask if we have a motion to approve the minutes from the November 20th board meeting.
Chair Bailey, this is Dan Kennedy. I move for approval.
Thank you, Mr. Kennedy.
And this is John Murray. I'll second the motion.
Mr. Murray, thank you for the second. Melissa, if you could please call roll to approve the minutes.
Dan Hartung.
Aye.
Lori Hoagland.
Aye.
Robert Judge.
Aye.
Dan Kennedy.
Aye.
Chris Lehman.
Aye.
John Murray.
Aye.
Vice Chair Amy Burns.
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. I would now like to call on Executive Director Ralph Magrish to provide us with a program update.
Thank you, Chair Bailey. Just a quick update, as I know I've got a number of folks signed up for comment this morning, so I will be brief. As you know, most of you, I believe, know at this point, I did present to our Senate Healthcare Committee, interim Senate Healthcare Committee during legislative days last Wednesday on our upper payment limit report. Not a lot of other news to report. I do, however, want to take a moment and recognize many of the changes the board has had this year, and that we've welcomed 3 new members. We welcomed Chris Lehman in February, Dan Kennedy in June, and Lori Hoagland in October. We've also seated a new chair with Shelley Bailey and a new vice chair with Amy Burns. We've staffed up our research and analytic team with Heather joining us in June and Paige joining us in July. So just want to take a moment and thank board members directly, our staff, our contractors, our counsel from the Oregon Department of Justice for everything all of you have done this year. We are excited about the new year and all that lies ahead. And with that, I just want to wish everyone a happy holiday season, a happy new year, and a friendly reminder that board meetings will start at 9 a.m. promptly beginning in January. Thank you, Chair Bailey.
Thank you, Mr. Magrish. This portion of the agenda is for public comments submitted or requested in advance. The board received 10 written comments, which are reviewed by the board and posted on the website. I am going to read who we received written comments from now, and then I'll introduce the 6 requests for individuals who requested to speak before the board today. So the letters that we received public comment on were from Ben Hughes from Health HIV related to UPL implementation, from Daria McGrew from Pharma related to the November 20th meeting and the UPL study, from Richard Blackwell at Pacific Source related to policy recommendations, from Zach Linkiewicz from HIV Policy Institute related to policy recommendations and affordability review HIV and medications, from Marianne Cooper, Regents Blue Cross Blue Shield of Oregon related to legislative proposals, from Jennifer Baker from Cigna related to policy recommendations, from Blasine Pinkowski, Chief Strategic Customer Officer at Johnson & Johnson Health Care related to UPL and affordability review, from Rainier Simmons related to annual report top 25 drugs, from Tiffany Westrick Robertson, ensuring access through collaborative health coalition related to policy recommendations and annual report, and from Bill Heath, PCMA, Assistant Vice President of State Affairs, UPL report. So as I referenced, the board did receive 6 requests to speak today. I will call on each of those assigned and ask them to state their name and organization. Each will have 3 minutes to speak. The board will not deliberate on issues or requests during this time. And again, I appreciate your willingness to keep in mind the 3 minutes for each speaker. So with that said, on our list, first is Daria McGrew from Pharma. Daria, welcome, and you now have the floor.
Good morning. Confirming you can hear me. This is actually Eric Lonis. I signed up. Daria won't be testifying today. I assume that works. Excellent. All right. Well, good morning again. I'm Eric Lonis with Pharma. Thank you for the opportunity to present public comment this morning. As Pharma has previously commented, the limited time frame that the board has afforded for review of the comments on materials ahead of its meeting does not allow for full and adequate opportunity to meaningfully participate by stakeholders on the important and complex issues before the board, which raises concerns both under the PDAP statute and the Oregon Administrative Procedures Act. Given the timing of the public comment period on the meeting materials published December 11th for this meeting, in addition to my testimony today, Pharma will provide written comment on January 7th with supplemental details for the board's consideration. With respect to the policy recommendations under consideration today, Pharma previously commented in our September 15th letter and hope these comments have and will be considered. A couple of items I'd like to amplify in my brief time. With respect to the policy on 9 drugs, while it's good for the board to have additional discretion over the number of drugs it's required to identify, we still have concerns with the language presupposes drugs are unaffordable prior to the affordability review. We agree that the transparency is needed with respect to AAPs and maximizers, and would strongly encourage the board to also consider alternative funding programs as well. Regarding coupons and PAPs, we need more detail on what is provided, and I think there is some confusion. These are different types of programs, and I believe the criticisms against them are based largely on insurance industry arguments that don't withstand scrutiny or consider the benefits accrued to patients. I'll now turn my attention to the UPL study that was voted on at the last meeting. As we noted in our November 26th letter, Pharma strongly disagrees with the board's rush decision on November 20th to vote and approve the draft UPL study, which we believe fails to fulfill the board's statutory mandate for a UPL plan, uses flawed assumptions and oversimplifications, and fails to adequately consider the full possible impacts of a UPL compared to other alternatives. I do want to commend the board members for the analysis and discussion you were attempting to have, which was a robust discussion about the value of various policy options in the report, attempting to struggle with the numerous concerns raised by stakeholders and yourselves as board members, and whether the structure of the report as written would adequately communicate the complexity of the subject matter when read by other audiences and not imply a recommendation or tacit agreement with the UPL. Unfortunately, a rush vote was taken. However, it was largely a function of being rushed. Executive Director Ralph McGrish on numerous occasions encouraged the board to speed up and discourage board members from spending too much time in order to be able to take a vote by the end of the meeting.
And Mr.
Board
Lawrence, I do want to reference you have used your 3 minutes, so thank you for your information.
Thank you. Thank you for your time.
I will now call on Lauren Sant from the Caring Ambassadors Program. Lauren, you now have the floor. Welcome. And as a reminder, you have 3 minutes.
Good morning, everyone. Lauren Sant, Caring Ambassadors Program Executive Director. I just have a couple of comments. And first, I do want to say happy holidays to all of you in case I forget at the end. On your policy recommendations, I didn't see anything about increased patient engagement. I know that you've had a hard time getting good patient engagement. We've discussed whether we need a stakeholder board. I think that should be a recommendation to the legislature that a patient engagement board is included. You need the resources to do that. You're not going to be able to do that without that being in your policy recommendations. So as a patient and as a community representative, I highly encourage you to consider adding that to one of your policy recommendations. And your policy recommendation number 8 on the dispensing fees, I would just really like to see some sort of language that says that those fees can't be paid by the patients. It's really unfair if PBMs are putting pharmacies out of business that patients would have to pay to keep pharmacies in business. So I would respectfully request that there be stronger language under number 8 to protect the consumers of Oregon. So thank you very much. I wish you all a happy holidays. Thanks for all your hard work. Look forward to working with you in 2025. But really, we need a patient engagement board and highly hope that you put that into your recommendations to the legislature. Thank you.
Ms. Sant, thank you for your time. We next call on Terrell Sweat from Johnson & Johnson. Terrell, you do have the floor, and keep in mind, please, that you have 3 minutes. Welcome.
Thank you very much. For the record, my name is Terrell Sweat, Director, U.S. State Government Affairs for Johnson & Johnson. Thank you for the opportunity to speak. J&J respectfully requests that the board take 3 actions. First, withdraw the UPL report and ask the legislature for an extension to resubmit it after the board has addressed stakeholders' numerous concerns. Second, wait to review a preliminary list of drugs until the board has established an updated methodology for selecting and assessing drugs with public input. And third, published documents will be presented or discussed during board meetings with sufficient time for stakeholder review and engagement. First, we ask the board to withdraw the UPL report from the legislature and ask for an extension to resubmit it. This will allow the board to take the time it needs to review the entire report and properly incorporate stakeholder feedback. At the last meeting, the board spent the majority of its time on the executive summary and did not have sufficient time to review the remainder of the report. The board was rushed into adopting the report and did not address significant flaws in the report, including biases and patients' concerns about cost shifting. Please refer to the previous comments for more detail about these concerns. Second, we ask the board to wait to review a preliminary list of drugs until the board has established an updated methodology for selecting and assessing drugs with public input. We were surprised to see that today's materials include a preliminary list of drugs for board review. As you may remember, the board voted on June 26, 2024 to pause its affordability reviews for 2024 so that the board could review, and I quote this, review, assess, and possibly improve, unquote, its criteria and methods to assess and select drugs using a refreshed data set. To date, the board has not taken any of these steps. Therefore, this list is premature. Third, staff should publish documents prepared for board meetings with sufficient time for stakeholder review. When documents are posted on the PDAB website a few days before a meeting, stakeholders do not have sufficient time to review and react to them. The board may receive more meaningful input if stakeholders have at least 2 weeks to review materials prepared for board meetings. At J&J, we know that Oregonians are counting on us to develop and bring accessible medicines to patients. We live this mission every day and are humbled by the patients who trust us to help them fight their diseases. Thank you.
Thank you, Mr. Sweat. Next on our list is Rainier Simmons from the Community Access National Network. Welcome, Rainier. And as a reminder, you do have the floor and you have 3 minutes. Welcome.
Thank you and good morning. This is Rainier Simons representing CAN, Community Access National Network. We're concerned today because your top 25 drug list for potential affordability review contains multiple HIV antiretroviral medications. Firstly, the Stauffer Myers report indicates that a UPL will result in lowered reimbursement across the board as a result of lowering the amounts of rebates received. Lowered reimbursement means a reduction in 340B revenues received from the purchase of HIV antiretroviral medication. This is damaging for the Ryan White program because Ryan White dollars fund the state AIDS drug assistance program, as well as other health services rendered by Ryan White care providers. These programs and providers also get a significant portion of their funding from 340B revenues. There are limitations to the things that Ryan White funds are allowed to be used for. Funding from the 340B revenues enables entities to provide vital services that are not eligible for Ryan White funds. A reduction in 340B revenues means a possible loss of life-giving services. Additionally, the base Ryan White funding the state receives is determined by a formula based on the number of people living with HIV in the most recent calendar year. The only way to get more funding is to be eligible for supplemental funding, which requires demonstrating severe additional need. In 2023, Oregon did not receive any supplemental funding, and the state of Oregon does not match federal dollars for Care Assist, the state AIDS drug assistance program. This indicates the state is not prepared to handle any loss of revenues. More importantly, antiretrovirals should not be on any list of affordability review. HIV regimens are complex and fluid based on individual patients' need. Successful health outcomes depend on unrestricted, full, and consistent access to all effective antiretrovirals. A UPL or any other cost containment action could adversely affect access to that ecosystem. 2 other state prescription drug advisory boards, Colorado and Maryland, already rejected the idea of considering antiretrovirals for consideration for affordability review or determined a specific antiretroviral is not affordable. Biktarvy and Genvoya are 2 of those drugs. The reviews determined that affordability of HIV antiretrovirals was not an issue because patients either benefited from very low insurance copays for the medications, or they were able to consistently obtain their medications through easily accessible manufactured patient assistance programs. HIV is one of Medicare's 6 protected classes, and at the end of 2023, there was reported 8,242 Oregonians living with HIV. To avoid damaging access to an already fragile antiretroviral ecosystem, we ask that you keep HIV antiretrovirals off of your affordability review list. Thank you.
Thank you for your time. Next individual who signed up to provide oral testimony is Tiffany Westrich Robertson from the Ensuring Access Through Collaborative Health Coalition. Tiffany, welcome. You now have the floor. And
Oh, excuse me, Chair Bailey. Tiffany is not able to attend today, so we'll move on to Jen Laws.
okay, welcome,
Thank
Jen.
you.
Jen, welcome, and you have the floor for 3 minutes.
Thank you, Chair and members of the board. For the Oregon Prescription Drug Affordability Board, I want to thank Rainier for providing some context as to my comments as we come in. The Ryan White HIV/AIDS program is an insular funding situation. The state of Oregon doesn't contribute dollars, and it hasn't, despite requirements to do so under federal law. Indeed, they've sought waiver. So the board should presume, based on past behavior, as well as provider stakeholders who may be listening and patient stakeholders who may be listening, that the state of Oregon will not further supplement this program. This program provides more than 61% of this program is rebate dollar revenue generated through the AIDS Drug Assistance Program Care Assist for Oregon. What that means is that anytime you take a hack at that in any way, shape, or form, you're going to see providers lose the ability to provide services, whether it's transportation, food, which is necessary in order to take antiretrovirals, or in the case of the ADAP, or the AIDS Drug Assistance Program, cut the number of people who are receiving free, and I mean no cost to them, healthcare services, as well as insurance premium payments and medication itself. The AIDS Drug Assistance Program reinvests every single penny of rebate dollars into extending access to care for the most vulnerable people living in the state of Oregon. This is not conjecture. Indeed, it's the reason why Colorado, specifically Chair Meisner in Colorado stepped back and said, you know what, I've never seen a patient living with HIV not be able to access their medication, not once, and decided to rule Genvoya as, quote, not unaffordable, as what they mean is affordable, right? But they don't want to come out and say that because that's the language of the statute. I get that. At the end of the day, you are talking about people who are highly marginalized. In order to qualify for the Ryan White Care Program, you have to be, your income level has to be at 500% in Oregon, at 500% of the federal poverty level or lower. Most often, people living with HIV are already living at or close to the poverty level in and of itself. Additionally, Medicaid covers most of these services and medications with limited to no restrictions because that personalized care is necessary. The board should not be considering any kind of medication for the treatment of HIV because of how fragile this ecosystem is, because of how dependent this ecosystem is on rebate revenues, and because on the back end, on the private NASDAD, the National Alliance for State and Territorial AIDS Directors, has already negotiated acquisition rates lower than the 340B floor for these medications. This work is already being done privately. The public system that is taking care of patients across the board have already taken care of this piece. The issue of affordability in HIV does not exist and has not existed for 30 years because of how this program is designed. The board would do well to pay attention if it says and meaningfully says, according to its own report, that it values what other states have determined and included that
Chair
information,
Bailey.
and not consider
Thank you
these
for your
medications.
comments. Thank you for your comments. Okay, so Courtney, let's see here. I'd like to give some background related to the October 2nd, 2024 meeting as board members began to review the 2024 proposed policy recommendations to send to the Oregon Legislature. At the October 16th meeting, PDAB staff gave a presentation related to the policy recommendations with a board discussion. Today, board members will continue that discussion and vote on policy recommendations. If the board votes to advance policy recommendations, they will be included in the annual report sent to the Oregon Legislature in December. I now call on Courtney Whitlock, Senior Policy Analyst, to help facilitate starting this conversation. Courtney, you now have the floor. I also do want to note for everyone listening in that we will take a 5-minute break at approximately 10:45 a.m. Pacific. So Courtney, welcome.
Thank you, Chair Bailey. Appreciate the time to speak with the board about the upcoming around the discussions for the policy recommendations and for recapping the kind of what has the conversations starting back in September regarding days. I just wanted to highlight real quick that our statutory requirement under Senate Bill 844 for our need for submitting recommendations. I need to share my screen real quick. Apologies. All right, hopefully everyone, you can see my screen now. Our statutory language indicates that we have an annual report to send every year. We'll talk about the annual report here in a few minutes. We need to get through the recommendations first. But just as a recap, recommendations, if any, for legislative changes necessary to make prescription drug products more affordable in the state. So as we review the recommendations, that we're following the statutory requirement that the prescription drug recommendations are to make the drug more affordable in the state. So let me go back to the recommendations. I'm going to just share a Word document. I'm going to track changes as best as I can. Any edits and changes to the recommendations. This is going to be kind of a live engagement. Starting off, kind of staff recommendations for the policy updates would be to have some language cleanup for the drugs. During the first initial review of the drugs, we were challenged, or the board was challenged with identifying the 9. So a suggestion would be to actually change the language to review up to 9 drugs annually to determine if any may create affordability challenges, and based off of the data provided. So starting with that, number 1, do I have any feedback, concerns, support for this drug or for this recommendation?
And I think, Courtney, Mr. Judge, you had your hand raised, so you can go first.
Oh, you're muted.
Thank you, Chair Bailey. I just want to make sure I understand the ground rules. So when we review each one of these concepts, we can discuss potential changes or edits. And then once we get through that, then we vote whether to proceed with it or not. And is that vote a unanimous vote or a majority vote?
Thank you for asking, Mr. Judge. I think the first thing to focus on would be the general concept of some of these, right? So if we kind of start this and in general, the board wants to proceed with them, maybe we'll leave any kind of small tweaks to the end. But to answer your question specifically, yes, we can do some kind of inline changes so that we could discuss them together as a board. I would just want to lead into making sure we're really focused on substantive inline changes. And then we will vote on each of these individually, and they will be voted as a majority. And so that would be the ground rules for the legislative concepts that we're discussing today. So thank you for asking that. That adds a lot of answers to help our colleagues through this discussion.
Thank you, Chair.
All right, so with that, Robert, did you have any feedback or anybody else on the board have any feedback suggestions for the first one to change language from 9 drugs a year to up to 9 drugs? Dan Kennedy.
Yes. My comment is that I think setting this at 9 drugs a year is a sort of self-limiting discussion, whether or not we have 9 drugs a year or not. We have to dig up 9 drugs a year. So I think up to 9 drugs a year gives us greater flexibility in determining our way forward. So my comment is yes on up to 9 drugs a year.
Thank you, Mr. Kennedy. Robert, I saw your hand up. Did you have further comments on it?
Not a further comment, just an affirming comment. I agree.
Okay. Dr. Hartung?
I mean, I generally agree with this. I would say that it, we're picking 9 drugs to do the affordability. We're kind of in making this process of figuring out which were the 9 drugs we want to do an affordability review on. We're kind of doing if we think that a drug doesn't need an affordability, we're kind of doing a implicit affordability review on that drug. So if I understand what's being proposed, we're basically saying we don't think, the 10th drug needs an affordability review because of something. So I'm fine with the language of including more flexibility, but and I'm cool with kind of voting for this, but that was just a general thought about the process.
Thanks, Dan, or Dr. Hartung, appreciate that feedback. Chair Bailey?
Yeah, I apologize to do this to you, Courtney, but I just realized I left someone off the list for public comment. So I do want to provide the 3 minutes of public comment to Brian Warren. Again, my apologies to everyone for this, but I do want to make sure that we provide Brian with the 3 minutes that he had signed up for. So Brian, you have the floor for 3 minutes. I apologize for omitting you previously.
No problem. Thank you, Chair Bailey. And good morning, board members. Brian Warren with the Biotechnology Innovation Organization. We just had some general comments as part of your agenda later today, specifically looks at reopening or drug selection process for next year's affordability review. Wanted to take a moment to step back and remind everyone that in June, the affordability reviews were paused last year or this year. And part of that was because there were a lot of unanswered questions like affordability for whom and many questions. And I think that ultimately the lesson was that you as board members found that this process was complicated enough that trying to build the plane as you fly it was not working. We encourage you to not do that again. And as obviously the drugs that are eligible for affordability review are based on statutory criteria, and having that list and looking at that list is perfectly fine. But before you start to embark on an affordability review process, make sure that we are talking about selection criteria and other elements of how you will be taking the drugs from those eligible and getting towards your process of conducting affordability reviews, so that you have a process that takes into consideration the policies that you're trying to promote. We also wanted to just take a moment and mention that last week, as the board's report was submitted to the legislative committee, the Senate Health Committee, we were a little concerned with, as you as board members discussed the affordability, the SB 192 UPL report. There are still a lot of unanswered questions with that process as well. And you all had a very robust discussion during that, and still it appears have many reservations. However, as this information was submitted to the board, to the legislative committee, the overall sense was that this board seems quite comfortable with UPLs and quite comfortable with moving forward with UPLs and confident in their ability to lower costs for Oregonians. So we just want to put on the record that we feel there still continues to be a kind of a distance between where many of the board members have been and where the public perception of where this board might be. And we want you to, again, just take things with a slow and intentional step forward move in 2025 so that we have a process that works for everyone. Thank you.
Mr. Warren, thank you, and my apologies for omitting you previously. Courtney, again, my apologies for the interruption, but you now have the floor to continue.
All right, thank you. Let me share my screen again, get back to the conversation. So what I'm hearing from at least one is that it seems to be a go for at least the recommendations. Is the board comfortable moving on to option 2 to discuss now? All right, I see some nods. So second option, a recommendation from the staff would be to remove the criteria that DCBS provide the board with a list of prescription drugs that's based off of a calendar quarter. So there's some manufacturer reporting requirements that come in quarterly, or actually come in monthly, but the reporting department would usually submit them quarterly, and it's only for within that year. Our other part of our statutory requirement is to look at drugs from the previous year, and it's a little bit easier to have the manufactured drugs that are reported along with the carrier drugs that are reported within the same year for review and collected within that same time. It makes data cleansing and comparison a lot easier. So instead of just holding on to quarterly reports for a year, just change it to where it's just for the previous year, where the providing department just submits everything to us at one time, versus throughout each quarter from the current month that needs to be reviewed from the previous year. So happy to answer any questions about that. This is just kind of for a cleanup for process from the analytics component of the data cleaning. Yes, Robert. Oh, you're on mute.
Sorry about that. So I might be a little slow on the uptake, or trying to make sure I understand this correctly. I get the fact that we received data from the prior year, and we have that for use for analysis. And then you have the reference to the manufacturer requirement to give notice of a price increase 60 days prior to the increase occurring. Can you describe to me what changes in the relationship between those two distinct and different timelines? With them, if we're talking 2024, we have 2023 data that we're looking at. And if a manufacturer had notice of a price increase in 2024, would that not be factored until next year when we looked at 20? I just want to try to understand how the two are playing together.
So, and just to make it clear, so the reporting, quarterly reporting, or actually the monthly reporting that manufacturers submit is based on specialty drugs, right? If it meets if a new specialty drug comes to market, the manufacturers have 60 days or so to report it, I think it is. Otherwise, annually, they have to support their annual increases. And so you already have that from the previous year. So that aligns with the requirements for the carrier. But when we have chunks of other information coming in, it's just kind of sitting. We don't know how to compare it against prior information and stuff like that. It's really not an apples, I don't want to say apple to apple, but we're looking at different specialties coming on during where one of our statutory requirements is to look at the drugs from the prior year. So we're just trying to clear up the language to meet the requirements. Because otherwise we still have to go back and pull all the information for the manufacturer specialties for that full year. This is kind of a process cleanup for us.
Thank you.
Any other questions or concerns, or does that seem good? I'm happy to move on to number 3 because I would want to get to the other more meaty recommendations. All right, hearing none. The third one is to remove the generic drug report as an annual requirement. Currently, we have the generic drug report that's due June 1st. That kind of discusses the generic drug market. Other requirements under there, we'd like to include a more substantial annual report for the end of the year that includes the drugs that were reviewed, price trend information, and the recommendations. Kind of have everything in one report, so that we have more time to focus on the work throughout the year instead of also trying to provide another report. And there's not a whole lot of changes that happen in the generic market year over year. So another, like I said, staff recommendation would be to remove that report annually and then apply any meaningful information that's currently under that report into the annual report that's due at the end of the year. Does any board members have any concerns or any discussion around this one? All right, seeing none. Chair Bailey, did you want to look at voting on these ones before we move to the third, or just wait for the discussion overall and then come back to these?
I think we can go ahead if we don't hear any substantive comments that anyone wants to make related to these 3. Let's go ahead and vote on these 3 for efficiency's perspective so that we can continue on with the discussions. Do you have language? Then this would be the same language we would use on all of these potential recommendations. Any language we could add to the screen for a motion?
Yeah, Melissa, do you have that available?
Yes, I'm ready to share
We'll
that.
use that. I'd like to see us use that consistent language throughout any additional recommendations that we elect to vote on as a board today. Melissa, thank you for providing that.
All right.
So would anyone would anyone like to provide a motion related to, Daniel Hartung, you have the floor.
Yeah, I move to approve policy recommendations 1 through 3 to include in the annual report.
Thank you, Dr. Hartung. Do we have a second to that motion?
I'll second.
Thank you. Thank you, Ms. Hoagland. Melissa, can you please call roll?
That was me.
That was Amy Burns.
I'm sorry, for the record, apologies, Dr. Burns. The second was from Dr. Burns.
Dan Hartung,
Yes.
Lori Hoagland,
Yes.
Robert Judge,
Yes.
Dan Kennedy,
Aye.
Chris Lehman.
Yeah.
John Murray,
Yes.
Vice Chair Amy Burns,
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa, for your support. Courtney, if you could please continue with number 4.
Yes. Melissa, thank you. I'm going to reshare my screen. All right. So on to the additional recommendations, starting with number 4. This is regarding patient assistant program reporting to the drug price transparency program, where the requirements would be to include manufacturer coupons and any other payment that reduces the patient's out-of-pocket costs to fill a prescription. The board hopefully would recommend this as a requirement to the report on all patient assistance programs that they maintain or fund. Is there any conversation or comments regarding this one? Yes, Dan, I see your hand up.
Yeah, the bullet says expand patient assistance program requirements. And so is there some other existing requirements on the books about these programs that we're expanding upon?
That's a good question. Ralph, does DPT collect any other information regarding PAPs? As the manager for them.
Sorry, fumbling to find my mute button. Yes, there are limited situations now where manufacturers are required to submit limited information on patient assistance programs. This would expand that across all programs. To that point, Dan, I would say this has been a policy recommendation of the Drug Price Transparency Program to the legislature for 3 consecutive years. The transparency program did again include it this year as for the 4th time as its policy recommendation as well. And Robert.
You're on mute again.
Sorry, I'm on a roll here. When I looked at each one of these options, I think it's useful, at least for me, to have a common way to think of these things. And you know, I think about it in terms of what our mission is: affordability, access, and transparency. So I'm trying to evaluate each one of these. However, in the information that Courtney showed us earlier about legislative recommendations, there was a very specific reference to lowering costs, I think, or more affordability. There was, I can't quite recall where you had it, but it focused more on affordability than it did upon access or transparency. I think that was what the legislative direction was, or the legislative direction was. So when I think about affordability as an item, this proposal, I think, would increase the transparency around PAPs, and it can help the board understand how these programs impact drug costs or drug prices. And by including manufacturer coupons, I think the board can get a clearer picture of the net cost of a drug, not just the list price. So I think there's a lot of rationale for why this could be an effective piece of legislation to pursue.
Courtney, I see Mr. Kennedy's hand. So Mr. Kennedy, your hand is raised.
Yes, I would just like to concur with Robert Judge and say that I think the affordability part is really to the consumer. And so to the extent that these programs offer greater affordability to the consumer at point of sale, I think this should be included as well.
Lori, I see your hand up. Did you want to say something, Lori?
Yeah, I too believe this is very important for transparency and affordability focus. I have a question in terms of how fluid these savings are. Are they things that there's a lot of vague issue with this in terms of these programs being offered once a year, changing by the month. Is there any additional information that you may have about that?
I'll have Ralph answer if there's any additional, but one of the things also about these recommendations is that we do submit them to the legislators, and then they take and provide it through additional committees on how they want to look at this component. So if the expansion would come from their committees, and then they would delegate it to whatever department needs to oversee it. And it also would be clarified under the rule development of it.
So, and if I can, Chair Bailey, and I think we saw someone else having their hand up in addition to yours, but to circle back on the original question is that as currently in the drug price transparency program, manufacturers only need to submit information about patient assistance programs with their annual price increase reports. That's if they meet those specific thresholds. This would more broadly expand that requirement or provision for full reporting of all patient assistance programs. And again, as folks mentioned in note, the goal there to really develop a complete, comprehensive picture of affordability and to whom, a question that certainly the board has wrestled with over the last several years, and that we believe this would help illuminate that as a state-specific data set unique to Oregon as to whom in the state of Oregon is receiving that kind of assistance and how. And when I say whom, I mean aggregated, not individual, for anyone to get concerned about that. Thank you.
Yeah, Chair Bailey, I see your hand up.
Thank you. So I am in alignment with my colleagues related to number 4. I did just want to lean into a couple of comments I heard, though, related to affordability, and just wanted to mention that I've heard affordability to consumers reference, but I also personally believe there's affordability issues to the ecosystem in general that we need to be mindful of. So this was more of a comment, and I just heard it as we discussed number 4, but probably will come out throughout the discussion as well. So thank you.
Thank you for that clarification, Chair Bailey. So I also want to be mindful of time. We have a couple other recommendations to get through. Is there any other conversation for this one, or are we ready to move on? Dr. Burns, is your hand up?
Yeah, I just have a quick question on how we're going to vote. Are we voting? We should vote individually as we go, I would say.
Yeah. So if there's no other conversation, we can do the vote then. You'll need a motion, and then Melissa can do a roll call.
I'll make the motion for number 4.
I can stop sharing, and Melissa can share the motion language. And then Dr. Burns, if you can read the.
I make the motion to approve policy recommendation 4 as amended by the board today to include in the annual report.
And I think possibly for clarification's sake, Vice Chair Dr. Burns, do you mind using the language from the one with no board amendments, since we didn't?
Oh, sorry.
No problem.
A little foggy today. I still have a cold. I make the motion to approve policy recommendation 4 to include in the annual report.
Second.
Thank you for the motion in the second. Melissa, if you could please call roll.
Dan Hartung,
Yes.
Lori Hoagland,
Yes.
Robert Judge,
Yes.
Dan Kennedy,
Yes.
Chris Lehman.
Yes.
John Murray,
Yes.
Vice Chair Amy Burns,
Yes.
Chair Shelley Bailey.
Yes.
Motion passes.
Thank you, Melissa. Courtney, you have the floor.
Much. All right, so then on to number 5. For pharmacy benefit managers and insurers reporting on copay accumulators and maximizers, this would be to implement mandatory reporting on those copay accumulators and maximizer programs to ensure equitable access to essential medications and prioritize transparency. With enhanced reporting, the board will aim to monitor the impact of copay accumulators on patient costs and access to medications.
Courtney, if we can have Melissa toggle you back to the recommendation, please.
Oh,
Thank you.
that up. Am I sharing my screen again, or is it?
You're not.
There you go, Courtney. It is.
There
coming
you
up.
are.
Sorry about that. All right, so it's number 5 here. Does the board have any discussion on this? Dan Hartung, I see your hand up.
Yeah, I guess just generally, it would be, if it's possible, to provide some sort of really brief origin story for each one of these things. Assume this is kind of coupled with the first recommendation, in that, you know, the patient assistance program dollars, you know, the strategic move from payers has been to implement these accumulators and maximizers to try to defeat the patient assistance dollars coming in. And so this, I would presume this is also coming from the drug price transparency program to, again, get a clear picture about that. But this is very, very complicated, to the point that, not that I'm like have any special knowledge here, but I struggle to really get my mind around what these programs do. But yeah, just generally, you know, maybe a 1-sentence line about where these things came from would be helpful.
Not for the future recommendations, let more clarity on where they came from. Robert, I see your hand up again.
Yeah, and it's just Dr. Hartung, I'm kind of on the same page. And I'm a little foggy, but I thought this past legislative session, there was legislation that was passed that banned the use of copay accumulators and maximizers. And if that's the case, do we need this?
And Robert, if I can speak to that, and I think your perception is accurate, a couple of things as it relates to the actual policy considerations here and the idea to expand reporting on these programs. And really that is that this is all about increasing transparency around accumulators to give policymakers and consumers key insights into some of the following questions. And yes, if it is obvious, I am drawing upon the DPT annual report when I ask this. The questions of what insurance plans have the most affordable prescription drug plans for consumers with certain medical conditions, which drugs are more affordable alternatives are currently subject to copay in Oregon. How do copay accumulators affect formulary development, including drugs that PBMs select in their tier level? How has House Bill 4113, for which you just mentioned, changed consumer out-of-pocket healthcare expenses? And finally, how does revenue captured by copay accumulators affect premium rates? So that is really, I think, the ultimate spirit and intent of gathering this kind of information to help inform legislators.
So just to kind of sum that back up, really to kind of do this type of mandatory reporting, it's really an attempt to kind of reveal their prevalence and the impact of these programs on that would allow the board to make.
No, specifically, I would say I think it's spot on at 70,000 feet for the first part, but more ultimately to inform the legislature, certainly to inform the board in policy recommendations, but ultimately the legislature in potential policy action.
Okay. And some of the complexities of this, and I don't want to take all the air in the room on this, but I spent a certain amount of time kind of thinking about this area. When we look at this type of mission, there tends to be in the industry a bias that copay accumulators raise costs for consumers when in fact their health insurance plan establishes what their obligations are. And what the copay accumulators try to do is to make sure that that continues to happen so the benefit can be kind of appropriately applied. from a premium basis. So would it be studying it? Or would it, I'm just trying to understand what's the presumption going into this about copay accumulators. They're bad things, and therefore we want to see how they're being used, or they're effective here but not here. You know, I'm trying to get an understanding.
Sure. I don't think any of this is to gather information or suggest any kind of indictment on these programs. It, I believe, is simply to gather information to help inform the legislature make decisions that are in the best interest of Oregonians.
Yeah. Got it. Okay. Thank you.
Sure. And Dr. Burns.
Yeah, I'd just like to point out that, I mean, you gave us more information there with just off the cuff, like explanation of what this might be than that's what's here. Because this just says mandatory reporting, enhanced reporting. It doesn't really say anything about what that reporting is going to include. And I think that that's kind of troubling because who's going to define that?
Yeah.
And what does that mean? What is our recommendation really? It doesn't, there's no there. Sorry. I don't know about this. I was leaning towards it, but now I'm a little iffy on it.
That was the point of my question. Anyways, I'm confused by the wording.
Sure. So first, apologies if we were not able to appropriately prepare this to your satisfaction in that regard. We'll note is ample opportunity now if this is something that committee chooses to workshop or take a hard pass on, we defer to you.
Because I guess to Executive Director Maker's point, we can provide inline edits, especially based on the additional context that Courtney provided today, to make changes to number 5, if that's the desire of the board. And I get, go ahead, Mr. Judge.
Then I want to say that there may be a perception of bias because I'm on the insurer side, but I'm trying to think about this from a policy perspective. And right now it feels very generally worded. And I think workshopping it in this session would take a chunk of time that we have in our board meeting today to get to something where we might be able to find the right, get it across the line. That's just my perspective.
And let's see, Mr. Kennedy, you had your hand raised?
Yes. So my take on this is just to provide visibility and transparency into this sort of opaque area of accumulators and maximizers, because we don't really have a good understanding of it. And if we don't have any reporting on it, how are we ever going to understand it? That's my take.
Mr. Murray, it looked like you had your hand up. Please go first before me.
Okay, thank you. Yeah, I agree with Dan. I think the more information that we have gathered up, the better on this opaque system, please.
And I see Dr. Burns, you have your hand up again.
Yeah, I mean, I think that's fine, but there's not even an example of what that might mean here. It just says reporting. And as you pointed out, it's an opaque system that needs a little bit of daylight. I don't disagree with that, but there's no definition here. So I'm just, it feels like a platitude, like let's do this, but let's not give you any advice on how to do it. Like we're, as the experts here, as the board, like we're not giving you any kind of guidance on what that might mean.
And Chair Bailey, you have any feedback or?
Thank you, Courtney. Yeah, the only thing I would just like to kind of call out, both for this as well as for all the other things that we're going to discuss, is a reminder that this is not the first time that the board has seen much of this language. So again, I recognize that this was the set aside time in December for us to do this, but some of our processes possibly related to giving feedback or feedback to staff when we see things as board members that we might want clarifying questions on. I think that's a discussion that as a board we need to have so that we would have some of the answers to things that board members have seen in the past that have questions on. I do think that's a process related thing that as board members, we could lean into more. Mr. Judge.
I think Dr. Hartung beat me to it.
Dr. Hart.
Oh, I mean, so I guess my only comment, if we want to proceed with this one, would be, I feel like this is coupled with the first one, in my mind, and maybe if we want to proceed, say, report that it was PBM and insurer reporting on copay accumulators and maximizers to the drug price transparency program, they're kind of the experts of collecting all this data. So, so it's kind of, we get one side, we get the patient reporting programs, patient assistance programs from the manufacturers, and then we get the copay accumulator maximizer stuff from the payers essentially. And that kind of provides this unified picture of what's going on with kind of out-of-pocket costs and how they're being handled and processed by either by patients or by payers and PBMs.
And Robert, I'll have you comment, and Lori, and then I'll follow up with some stuff.
I have a suggestion that instead of kind of getting to we want data, I think what we're talking about is we would really be advantaged by understanding. So it could be that this could be modified. So it's a report that the drug price transparency group would be responsible for preparing on what they are, what value they deliver in the marketplace for both consumers and payers, so that we can be informed about it. And then based upon being informed, then we can determine next year whether to collect data on it. I mean, I think we just need to kind of understand what it is we're collecting. Data is useless unless we know what the data is we're collecting it for. I don't know if that's a motion, but it's definitely a thought.
Let's listen to Lori, and then I'll respond to that in just a second, Robert.
I think looking at this from a bigger picture, there's a lot of distrust with PBMs, both in the state as well as currently in the federal government. And what we're telling the legislators is that we want more information, that we need to continue to ask, demand, expect all of the details so that we feel like we have maximum transparency.
Yeah, thanks, Lori. I think there's a lot of things. One, we need to ensure that it could even go through DPT. So I don't want to add them into this until it's clarified. Again, if this is a recommendation that doesn't need to go through for this year, we can readjust it next year and add more information to it. We do have other recommendations we really need to get to. We're kind of getting up against time. I want to make sure we have enough time for the annual review report as well to vote on, and then the review of the preliminary list. But so does the board want to do high? And I guess Ralph, I'll have to ask you, would this even come from DPT?
Yeah, so thank you, Courtney. This would be a reporting provision to the drug price transparency program and to the point that was made earlier as to, what level of detail would be appropriate in this, I will tell you that this, as with all reporting requirements, including that for which the PBMs are now reporting to that transparency program as well, we'll go through a rulemaking process. So that level of detail would be defined through that transparent rulemaking process. This is conceptually, again, to capture what and how PBMs, and to many of you and insurance companies, the points have been made. And I would think, to the other point that was made, if there are issues or concerns about affordability, we're seeking the ability to gather information to make informed decisions about one side of the coin, being number 4, to be able to see the whole picture. I believe that seeing the other side of that coin, being number 5, is highly relevant to that too, so that the whole story can be told. Again, level of detail and specific reporting provisions to be determined in rule, should the legislature grant that authority. So appreciate that, or there's discussion about what that might look like in technical aspects, but that is a longer runway conversation should the legislature go with this. Dr. Hartung.
Yeah, so I think I'm wanting to move to approve recommendation 5 with the small edit of pharmacy benefit managers and ensure reporting on copay accumulators and maximizers to the drug price transparency program.
And Dr. Hartung, thank you for that motion. For consistency's sake, I am going to ask Melissa to pull up the motion language, if you wouldn't mind rereading that.
Bailey, can we just check in that John Murray just raised his hand? Not sure if that was specific to a question before any motion conversation. Thank you.
My apologies. No, I was going to second the motion. I can wait until it's restated.
Okay. So I move to approve policy recommendation 5 to be included in the annual report with the edit of stipulating that these data be reported to the drug price transparency program.
Do we have a second to that motion?
I will second the motion.
Thank you, Mr. Murray. Melissa, if you could please call roll.
Dan Hartung,
Yes.
Lori Hoagland,
Yes.
Robert Judge,
Because of an appearance of conflict of interest, I'm recusing myself from this.
Dan Kennedy,
Yes.
Chris Lehman,
Yes.
John Murray,
Yes.
Vice Chair Amy Burns,
Yes.
Chair Shelley Bailey.
Yes.
Motion passes.
Thank you, Melissa. Courtney, you now have the floor.
Thank you, board, for that vote. I made the edits up here. So on to number 6, which is to uniform reimbursement rate for critical access pharmacies, also known as CAPs. This applies to all PMM CAP contracts with uniform reimbursement rates and non-discriminatory reimbursements. Chair Bailey, I'm gonna lean in on you for some of this information to apply to the board for any questions.
Yeah, absolutely. So based on the question from Dr. Hartung related to the origin story, this origin story is a proposed concept that I did write. I did provide a few proposed legislative concepts. All board members were asked if they had proposed legislative concepts that they wanted to put forth to the board. So this is one of them that I did put forward to the board. However, for the record, Courtney, I would like, as we begin the discussion, and this will be the same comment that I make related to number 8. When I personally had provided this comment to staff, I had omitted a very important piece to this, and I can put it in the chat, if that is helpful, but I'll at least first state it orally. I do, related to the CAP dispensing fees, that would be in relation to pass-through pricing with payers. So there are 3 states at least right now that have pass-through pricing that have saved their states millions of dollars. And so I wanted to recognize that for critical access pharmacies to receive elevated dispensing fees, personally, I believe that there has to be a pass-through pricing piece to that discussion. I do have proposed language I could put in the chat, but I did want to make sure to put that in. And for the record, I believe the cap dispensing fee, and others on the committee could help clarify that. I do believe the cap dispensing fee right now for fee-for-service Medicaid is $14.50.
And Chair Bailey, where within these 2 bullets?
I guess it would need to be actually just one additional bullet. I recognize there are other people who want to provide comment. I will work on, I guess there isn't a way to do a chat in this.
We have this, there's no chat function. If anything, you could probably email it to me and then I can apply it into.
Okay, while my colleagues discuss this as well, I will provide it via email. I wasn't sure the platform to use to do that, so I will work on that.
John Moore, I see your hand up.
Yes. In discussing the preparation for the meeting, someone asked me if I was willing to die on this hill. And while I'm not a single topic person, it did make me think later that I appreciate it. Well, it made me think that I didn't die, and I'm not willing to die on this hill particularly, but 50 of my colleagues died in the last 1.5 years in the state of Oregon, making us firmly in place, 2nd place in the state or in the nation for access to pharmacy care. I was really glad to see Mr. Judge's comment about our mission earlier in the meeting, affordability, access, and transparency. I couldn't agree more. One of the statistics that I came across in thinking about this topic and trying to keep pharmacies in business in the state of Oregon, whether they're caps or not, is that the CDC estimates, even in 2017, that $300 billion of direct healthcare costs results from medication unadherence, people not taking their medicine as they're supposed to. A lack of pharmacies doesn't help that. And if we're trying to save money for the state of Oregon, I think that we need to seriously look at bolstering the system that we have. If we keep deteriorating, we can have affordable drugs all we want, but no one's going to be able to get them. So that's my initial comments. Thank you.
Dr. Burns, I see your hand up.
Yeah, Chair, can I ask Chair Bailey a question?
Yes, absolutely.
Awesome. So just to clarify, because when I read this, I read reimbursement rate, meaning not just the dispensing fee, but the cost at which the drug is dispensed for the drug itself. Are you meaning the entire kit and caboodle, or is this really meaning dispensing fee?
Thank you for asking. My intention with it was related to dispensing fee and the kit and caboodle, which would be a little bit more in alignment with the language in number 8. I certainly believe I did not provide as clear of language as I otherwise could have. And I did also just email the additional proposal to staff that they could maybe share. But I did mean it as what states such as Kentucky and Tennessee and West Virginia have done related to making sure that a pharmacy is paid at NADAC plus their dispensing fee. In Oregon, we have AAAC, so we don't, we could use something that's more in alignment with cost of goods for Oregon pharmacies. So that was a long-winded answer to your question, but thank you for asking.
Okay, and this would apply to all insurance companies, commercial, et cetera.
Yes, which is in alignment with what some other states are doing at this time.
Okay, thank you.
Mhm. While Courtney is editing that, Mr. Judge, I'll give you the floor.
Yeah, I think I want to maybe edit what you said, because I think there may be some ERISA
No.
elements related to this, so it would not be uniform to all types of plans that are out there. That's just kind of an editorial. So I struggle with this. I'm a strong believer in the critical access pharmacy program and the requirement to make sure that we, especially in rural areas, that we have that provider network available for our rural communities. What I'm unaware of, and I get a little confused on this, is I know that there is a cap defined in rural for the Oregon Prescription Drug Program, which is just for Oregon prescription drugs, drug program. Is there another rule that describes what a cap is? And are they the same definition of caps? I don't know. But my sense is that there may be more than one definition, and it may be quite different. So eligibility for what is a cap and what isn't a cap is a big question mark for me. And then beyond that, when I think about kind of the points that I said at the top of this, affordability, access, and transparency, this clearly gets at access, but it really is primarily focused on a very small network of pharmacies. So it's going to have no effect, real measurable effect, on the PDEB's mission of affordability and transparency.
Mr. Judge, thank you for your comment. I believe that Mr. Kennedy had his hand raised next. Mr. Kennedy, you have the floor.
Yes, I just wanted to, just as a point of information, say that I think currently there are 51 cap pharmacies in the state of Oregon. And I would just say that one of our goals too is to ensure equity. And I think access and equity go hand in hand. Underserved areas are not able to get prescription drugs, whether affordable or unaffordable. And I think that's an important element of this as well. Thank you.
And while Courtney is editing, I see that Mr. Murray has his hand raised, so I'll just help facilitate this. Mr. Murray, you have the floor.
Yeah, thank you. I wanted to provide some information for Mr. Judge, who was asking about critical access pharmacies, and recently Oregon Health Authority did a definition of critical access pharmacies and how they're designated. And ArrayRx, we just received a list of critical access pharmacies in Oregon. As far as frontier or rural zip codes, frontier, there's 14 pharmacies. Rural zip codes, there's about 40. And urban zip codes, there are 11. So it does cover the majority of a lot of the state. It isn't necessarily designated simply by rural. They service all of the most needy patients in the state, generally speaking. Thank you.
All right, Chair Bailey, I applied the edits, just number 6 into number 8. Was that?
Yeah, thank you. My apologies for adding that ad hoc, but it was an important piece of it. And so that's why I was helping to call on board members while you were making those additional additions to number 6. Mr. Judge, your hand is raised.
Yeah, I was just wondering if staff can help me understand. And John, thank you very much for kind of describing what the rural expansion applied to. And actually, I think the number of pharmacies is closer to 60 some odd now. But that's in OPDP or ArrayRx land. And I don't know that it applies to every other payer in the state. So can staff help educate us as the board as who defines the cap and who's
Sure.
obligated to support it?
So, Robert, we'll give this a whirl. I think you are correct in that that designation is specific to the Oregon Prescription Drug Discount Program. I'd say that without certainty. I would say if this is something that the board chooses to advance, either it would be caveated or assumed. Also think that we probably would want to hear from perhaps Dr. Burns, based on her experience in her professional life as to the practical aspects as it relates to an action like this, so that the board can hopefully make very fully informed decisions on a thumbs up or down on this.
I think Lori had her hand up first. I'm happy to cede the floor.
I just wanted to emphasize the equity mentioning. I appreciate that in my professional experience, access in situations with poverty and marginalized communities is huge. If you can't afford to get on a bus and get to a pharmacy or fill your car with gas, it's a big deal. So I'm just glad we brought that up.
Dr. Burns, did you want to respond back to Ralph's engagement?
I think that it's this is a nice idea that will be very difficult to implement and probably not possible for the breadth of what is being asked for to happen. And I don't believe that it will make drugs more affordable for consumers. But I do agree with the sentiment behind having CAP pharmacies better reimbursed. I just think both 6 and number 8, when we get there, are written in such a way that they aren't actionable. It would have been more practical, at least in my opinion, to have split up the different actions here, so that perhaps they could have been attacked or, acted upon in a way that would make sense and could happen in a stepwise fashion. That's just my opinion.
Please let Mr. Murray and Mr. Judge go before my comments, but I will still keep my hand raised.
Do you have a comment, Robert?
Oh, I'm sorry. I thought Mr. Murray was going to go first. Just 2 comments, and I appreciate what Dr. Burns said. So there's this tension between 2 concepts or 2 of our objectives inside of PDAP. One is affordability, the other is access. And I totally get that if pharmacies go out of business, rural pharmacies especially go out of business, then access goes out the window. So totally believe that it makes sense to keep critical access pharmacies around and reimbursable. The specific challenge I have with the recommendation as drafted is it applies to OPDP because that's where the rule generated. It may apply to Medicaid, but it doesn't apply to anybody else. And so I'm sitting there going, we're trying to talk about this as if it's uniform, and it's not uniform. So I think it's a good concept, poorly worded, and should not be executed on as a recommendation without some with having some obligation that all payers must use CAP, and then you're going to get into some really interesting conversations.
There's been some comments and public testimonies sent to us and discussions around that. Representative Rob Nose with the House Healthcare Committee has been holding workshops through the summer. This is actually, there is a bill drafted to address this point. It's LC 2723 at the moment, but hasn't been assigned a different number. So these kinds of concepts, including this, are in these, are already being put forth, where we might differ, I guess, a little bit amongst board members here on our focus as far as affordability. Who is it affordable for? I think that access is important. So it doesn't matter how affordable these medications are if no one can get them. And pharmacies need to be in business in order to do it. Our current model isn't working. I think that's why we're in business right now, this board. And so we continue down the road of doing little or gathering information until we're completely first in being lack of access in this nation. I don't think that's going to benefit any of the people that I hope we're trying to benefit, which is the citizens of our state, not PBMs, not manufacturers, not insurers, although, some of them are mentioned in our Senate bill goals. I would hope that our patient is also in there too. So I'm firmly in support of 6 and 8 for that matter, and they will be topics of discussion. They will be worked through. It's not a short session this year, it's a long session, and I'm quite sure we'll be discussing this a lot. I do appreciate the additional comments that Chair Bailey added to number 6, and I assume to number 8, but we'll wait and see. So, thank you.
Thank you, John. Chair Bailey, do you have any comments?
Yes, I do. Thank you, Courtney. So a couple things I would like to add just when we look at comparison. So again, I believe the cap rate is $14.60 currently in Oregon, but just for overall visibility, I would like to share that in Tennessee specifically, the TennCare rate for all pharmacies of a minimum dispensing fee is $13.16. So some of this language was pulled from states such as Kentucky, Tennessee, and West Virginia related to what something like this could look like. The other thing that I do want to just mention for the record is the comment related to the practicality of being able to implement things. That's not something, and we've had very broad strategic discussions about many things related to affordability, and we haven't limited ourselves specifically related to practicality of implementation in the past. So I caution us to when we add that type of language about one thing, but not about other things that are being discussed, because as a board, we have discussed many other things in the past that have never been implemented before, and we have not leaned into the practicality of the issues. So it's important for me to be on record to make sure to mention that.
Vice Chair Burns.
I would suggest that we make, and I made these suggestions before, that we have the dispensing fee as a separate recommendation. I made that suggestion on number 8 too. I think that that makes a lot of sense. I think there is a lot of movement behind that, and that is a really good, I won't say practical or actionable recommendation. That's something that you can point to states like Tennessee and say, look, it worked here. And I think that's a really good recommendation. So that's what I would recommend for this. But yeah, I don't know. It's a lot for one thing.
Vice Chair Burns, can I ask you a question then specifically related to that in Tennessee?
If you want to, sure.
Okay, thank you. I just wanted to call out that Tennessee does have that TennCare rate of $13.16, but they also in their statutory language do link it to NADAC. So there's the NADAC minimum reimbursement piece coupled with the elevated or the agreed to dispense fee. So they have both pieces of that in their statutory language.
Yeah, you've said that. I heard you. Thank you.
I definitely appreciate the conversation from the board members. Are we at a point from the conversation to make a motion or a vote or for this recommendation?
I would say, Courtney, whether or not we have a motion, can you please put the motion language on the screen so that can help guide the board members here today?
Absolutely. Melissa, can you please? Thank you. And I know that the language says approve, but you, I believe board members can make kind of an edit to that, if it's not. I'm
There
sorry,
is
yeah,
board
sorry.
amendment language.
Go ahead and approve, and then you, apologies, yeah, go ahead. Robert, I see your hand up first.
Yeah, just a question in terms of intent behind this, because I'm always concerned about unintended consequences. If we did this, but I am a cash paying consumer, or I have a high deductible, or have you just increased my costs?
Is that a question?
Yeah, it's a question. If we do this and you have consumers out there who are covered but have high deductibles, or if you have consumers out there who are maybe cash pay, would this requirement essentially result in an increase in costs for them? And is that our mission? Because that doesn't address affordability.
The only answer to that I could say, Mr. Judge, is in the states that have implemented that, they have seen tens of millions of dollars of savings. And so at a patient level, I guess there would be the transparent information related to NADAC that they could look up and see. But as an ecosystem, there has been significant savings that are documented. And some of those are in the footnotes of our report that we advanced to the legislature last month. Again, doesn't mean that was agreed to by all board members, but that information was footnoted in that document.
So the net of that is, I'm sorry to you, Sarah, but the healthcare system is better because of this.
I believe it would be a projection to reference that for a cash paying patient, whether or not they would receive an increase or a decrease. I personally haven't seen the data at a patient level, but I think we also could appreciate that most specialty medications, there are programs for individuals, and that the cash pay piece may not be as pronounced as it might be perceived.
Thank you, Chair.
Dan Kennedy, I see your hand up.
Yes. I would like to move to approve policy recommendation 6 as amended by the board today to include in the annual report.
Thank you, Mr. Kennedy. Summary.
I'll second the motion.
Melissa, can you please call roll?
Dan Hartung,
No.
Lori Hoagland,
Yes.
Robert Judge,
No.
Dan Kennedy,
Yes.
Chris Lehman,
No.
John Murray,
Yes.
Vice Chair Amy Burns,
No.
Chair Shelley Bailey.
Yes.
The vote is 4-4, a tie, so the motion fails.
Mr. Murray, you had your hand raised.
Yes, it had to do before the motion with the idea that it would go directly, the increase in cost would go directly to the patient. And personally, I liked the comments by Lauren Sant with Caring Ambassadors about requiring that PBMs not pass that on to the patient. I've seen that in real life. I've seen customers that come up that may have chosen a particular plan or something like that, and the cost is passed right on to them. And so, yeah, I would, I guess I would have included that in the motion as well.
Well, and one thing, Mr. Murray, that was an additional bullet. Again, it was just added very much during our discussion during the meeting, but I do think there was a bullet related to at no additional fee to the patient. So hopefully board members did see that when they were voting and discussing on that.
Yes.
I can share my screen again. The motion failed, so the rule will not, or the recommendation will not go forward.
Courtney, if I may, just a couple quick things and then deference to you on when we should schedule a break, if that's what the board wants to do. But recognizing that in situations such as this, for consistency and fairness sake, we did have a 4-4 tie in our last meeting on a vote, if I'm recalling right, and procedurally, we should afford the board opportunity to engage in further discussion on that, should they be so inclined to do so before we move on. So let me invite Chair Bailey and Vice Chair Burns to make that decision call if they want to facilitate additional conversation on this to try to reach a vote up or down or to move on.
Mr. Magrish, thank you for making that comment. I guess related to that, I would ask, and maybe particularly anyone who voted no, is there any additional language that might change your vote, either language that would be deleted from the language in front of us today, or additional language that might change how you voted on number 6? So if that is anything someone wants to entertain, it looks like Mr. Judge, your hand is raised.
Yeah, I mean, my challenge with this was the lack of uniformity and applicability across all types of payers. That would not change my perspective, but you know, that's just giving you insight on kind of one of the limitations I saw with this bill.
I think thank you, Mr. Judge. Let's focus on anyone who has language that would change how they voted on it, either additions or subtractions from what we're looking at right now. Okay, so from my perspective, I don't hear that anyone has any substantive changes that they would like to make related to number 6. So Courtney, if you could please help advance us to the discussion on number 7. I can provide additional context to help any board members related to that.
Okay, so number 7 concept. Actually, before we continue, did we want to take a quick break and then come back? Chair Bailey?
Yeah, let's go ahead and take our 5-minute break that we referenced. Apologies to everyone here that this was delayed. So we will come back at 11, let's say 11:14 Pacific. Okay, my timer's going off. I'd like us to continue our meeting. Melissa, can you just do a quick roll call so we can make sure we have quorum?
Yes. Dan Hartung.
Present.
Lori Hoagland.
Present.
Robert Judge.
Present.
Dan Kennedy.
Present.
Chris Lehman.
Present.
John Murray.
Present.
Vice Chair Amy Burns.
Present.
Vice Chair Shelley Bailey.
Present.
We have a quorum.
Thank you, Melissa. And I would just like to step in and say before Courtney continues, Mr. Robert Judge, I heard what you said earlier about needing to leave the meeting at 11:30 today. So I would like to ask you, as we continue through these bulleted items, again, I would like to continue to go in order, but as a courtesy to you, do you have any specific ones that you feel more strongly about than others that you would like to make sure your voice is heard for the record? And if so, can you please direct us to which one you would like to focus on? And then we will continue on the others as you're absent from the room, but we will still have quorum to vote on those.
Yeah, I thank you, Chair Bailey. I think, and this isn't in order, but 7, 8, and I'm sorry,
I'm in the
9 and 10. I'm
Mr.
sorry, 9
Judge,
and 10.
Mr. Judge, you can pick the next one. You have the
Okay,
power.
I can pick the next one. So can we do the next one in order, which was the broken one? I think that would
Okay,
be.
so you would like to next focus on number 7. All right,
Yeah.
thank you, Mr. Judge. Courtney, if you could continue and I can provide any clarifying information.
Chair Bailey, again, board members, is there any questions, feedback? or edits that you would like to see made to number 7, which is the Consolidated Appropriation Act, or the CAA, disclosures about reimbursement and fees to employer plans from brokers. And this includes any broker or any entity facilitating the purchase of health insurance and prescription drug benefits for purchasing entities. They must provide an annual disclosure of all direct and indirect compensations received as required by the CAA. This disclosure must also include any compensations, fees, or any other forms of compensation related to their transactions. Another portion of this recommendation would also have brokers proactively offer these CAA compliant disclosure schedules in writing to the relevant purchasing entities, which includes OEB, PEB, FFS, Medicaid, ARX, etc., during the contracted negotiations and renewals, and no later than 60 days prior to the renewal of any contract or service agreements. So, Robert, yes, Shelley.
Oh, okay. So to the question of Dr. Hartung kind of asking for the context related to different concepts, I wanted to give the context to my colleagues here today that the CAA is already the law of the land as of 2021. My intention for providing it here was to make sure that board members and legislators are aware of this law, as well as to provide a bit more of a vehicle that and kind of framework that we can use here in Oregon to make sure that purchasers know they can request this information, and that there is a kind of defined process to be able to do this. But the CAA is a law as of 2021, but it is a compensation. This compensation piece is, from my perspective, does impact affordability, and that's why I presented it as a legislative concept today.
Board members, is there any additional discussion or comment regarding number 7? Dr. Hartung?
Yeah, thank you, Chair Bailey, for that explanation, although I'm still a little bit confused about how this is the direct relevance to our kind of scope of activities and what we're supposed to be working on. So as written, I'm not going to support this.
Thank you, Dr. Hartung. I see Robert Judge, your hand is up.
Yeah, I was going back and forth on this as well. On the one hand, bringing greater transparency into the supply chain, I think is really important for Oregonians to get kind of a handle on what's influencing costs. So that was the first look I took on this. But it makes me, again, it doesn't directly affect affordability directly, nor does it affect access directly, but addresses transparency. And my gut is telling me that there's a lot of logs laying sideways in the stream that add cost, and you don't know it because they're submerged, and you don't know them until you hit them. And this may be one of those logs.
I see Chris Lehman.
Director Mangrish, can you talk a little bit about what this adds? I mean, and the benefit that this will provide to our work?
Sure. I'm going to defer to Chair Bailey on this, Chris, as this was one that Chair Bailey brought forward to advocate for. So I really would like to defer to her for this.
And Dr. Lehman, I am happy to answer that question. Before I do so, Mr. Murray, does your question or comment relate in any way to what Dr. Lehman asked, or would you like me to proceed?
No, please proceed. I'd like to hear, actually. Thank you.
Oh, okay. Thank you. So Dr. Lehman, thank you for asking that question. From my perspective, I do want to mention just the fiduciary responsibility of purchasers of healthcare benefits. I'd like to make sure to share with board members some of the lawsuits related to fiduciary responsibility, the J&J versus, or Ludowski versus J&J. There are some other pending ones with Blue Cross Blue Shield, but from my perspective, coupled with some of the discussions that I believe we've had in previous board meetings, the many pieces of the supply chain end up directly impacting affordability, whether that's directly impacting affordability on insurance premiums, on copays from plan design. Various pieces do impact affordability both to the consumer and to the end payer. And so that was the lens from which I provided this information. But Mr. Murray, you now have the floor.
Thank you for that additional information. That furthers my belief that I think that I agree there are many logs in the stream that do affect affordability in the end. Knowing as many of them as we possibly can, I think does not hurt our mission. Thank you.
Any other board members have questions or comments? Otherwise, we can do a vote, or somebody can state a motion and we can do a vote.
Well, and Courtney, for consistency, and I'll make sure to give Dr. Lehman the floor next. Can you go ahead or have Melissa provide the language on the screen? Again, not referencing that I believe someone will provide a motion, but I just want to make sure that it's visible there. And Dr. Lehman, you now have the floor.
Chair Bailey, I'm happy to make a motion for policy recommendation number 7 with no board amendments to be included in the annual report.
All right, thank you, Chris. Is there a second?
This is Board Member Kennedy. I will second.
Thank you, Dan.
And Melissa, if you could please call roll.
Dan Hartung,
No.
Lori Hoagland,
Yes.
Robert Judge,
Yes.
Dan Kennedy,
Yes.
Chris Lehman,
Yes.
John Murray,
Yes.
Vice Chair Amy Burns,
Yes.
Chair Shelley Bailey.
Yes.
Motion passes.
Melissa, thank you for taking roll. And Courtney, if you could help us advance to the next one on our agenda, and I can help facilitate or add details as appropriate and necessary.
Chair Bailey. So number 8 is regarding fees and regarding dispensing fees and reimbursement fees across all payers. Identified as a minimum reimbursement fee for all participants regarding reimbursement to pharmacies at a rate that is no less than the average actual acquisition cost, or AAAC, on the drug plus the state determining dispensing fee. And this reimbursement structure shall apply to all prescriptions dispensed by pharmacies in Oregon, with the AAAC of the drug shall be determined based on the Oregon Medicaid AAAC pricing or the equivalent negotiate national pricing index adopted by the Oregon Health Authority, also known as OHA. This recommendation also includes dispensing fees that shall be equal to or greater than the dispensing fee used in Oregon's fee-for-service Medicaid program, which is currently at $10.65. And this dispensing fee may be updated periodically based on the updated surveys or economic conditions. Additionally, prohibiting of below cost reimbursements, which entails PBMs or payers, shall not reimburse a pharmacy at or below the pharmacy acquisition cost for any prescription drug. But the additional bullets that include all payers, including CCOs, commercial health plans, health insured plans offered through the state or federal exchange, and PBMs to utilize a pass-through pricing model for all prescription drugs. And then under such a model, the amount billed to the payer for each dispensed prescription shall be equal to the amount reimbursed to the pharmacy, consisting solely of the average acquisition cost for the AAAC plus the state determined dispensing fee. Lastly, the pass-through pricing model shall not alter payment copay amounts. I'm going to open it back up to the board members to have any discussion or to provide a motion. John, I see your hand up.
Yeah, thank you. I did want to suggest maybe one change to it, and it is in the first paragraph. Mr. Judge's comments about ERISA excluded plans probably does apply. I don't know that we can mandate as a state to federal programs, so I would make that suggested change. But this gives us, and I do have some further information actually on the Oregon Health Authority Medicaid division, exact amounts for the co-payments that are in place right now. Critical access pharmacies are $16.87 for prescriptions. That's the dispensing fee. And for 340B pharmacies, they recognize an additional need. It is $20.86. Just, I would make that, just as an example, because it refers to it as which is currently the dispensing fee. So I guess I would need to hear, we have a set dispensing fee, we have a set cost of the drug with a nationally recognized set list. I guess I'm curious from other board members what their concerns are about not supporting this. What do you find wrong or unpalatable with this policy recommendation? Thank you.
Go ahead, Robert.
Okay, sorry, yeah, and I'm not gonna respond to Mr. Murray the way he kind of asked about it, what I find wrong with it or objectionable, but I think it's helpful, at least in my mind, again, going back to my 3 criteria: affordability, access, and transparency, that a minimum reimbursement rate, which is what this is really talking to, doesn't necessarily, I don't know, because I've not seen the data, that it actually lowers overall drug prices. I think there's debates on either side. So that gets to an affordability issue. It could lead to higher costs. It could lead to lower costs. But so mandating it without any kind of the board recommending this forward without any kind of insight into what we're recommending, other than anecdotal stuff, is cause for concern for me. I do believe that it would address that access element, because it would provide a reimbursement that would presumably keep them operational, which is an objective. But and there's some transparency around it, but it really doesn't get to kind of the thing that I think the PDEB is trying to address, which is issues related to drug pricing. And even as we've had some discussions in the last, couple months around the transparency, the lack of transparency in the supply chain. So I struggle with, understand what we're trying to get at, but I'm not sure that this is the way to do it.
Vice Chair Burns, you want to go?
Sure. So the comments I had for number 6 apply to number 8 as well. This is really, to me, essentially the same structured, very complex, multiple issue recommendation, except now it's for all pharmacies. Again, I think it's trying to get at something really fundamental. I don't disagree with you, that's broken, but it's multiple things and should have been split up and looked at separately. So that essentially my comments for 6 or my comments for 8.
Great. Thank you so much. Yeah, Chair Bailey.
Go ahead and let Ms. Hoagland go first, and then I'll go after her.
The 340B pharmacies, any sense of how that would impact them?
I could say, Ms. Hoagland, because I did provide some, Ralph, before I continued.
Yes, Chair Bailey, thank you. I do want to flag, and John hit this earlier, and that it did just hit our radar just in the last few minutes, literally, in fact, that effective December 1st, so all of 2.5 weeks ago, OHA did change its dispensing fee structure for the fee-for-service program. It is, in fact, a tiered program. To Lori's question or point, 340B covered entity rates are $20.86, and then they move to a tier-based volume ranging from $9.99 at the lowest end to $16.87. So should this go forward, in the interest of time, I would encourage you likely just to strike that 1065 language and say something to the effect of as consistent with OHP fee for service. Again, that is not a statement of support or discouragement for this, but simply just clarifying that for folks. Thank you.
Ralph, thank you for adding that. Courtney, since my hand was raised next, I'll go ahead and go next since I don't see any other hands raised. I do want to make a follow-up comment to the reference of savings with benchmark pricing based on acquisition cost plus cost of dispense related dispensing fee as anecdotal. I would like to reference that there's data from many states, including California Medicaid, North Dakota, Michigan, Kentucky, Ohio, West Virginia, and others that have documented their savings. And some of those documented savings are cited in our report from last month. So I would just make a comment that I think the comment related to anecdotal isn't in alignment with at least the research that I've been doing on my end.
Thanks, Chair Bailey. I just changed some language in there just to make it match the information I just received regarding OHA's medical assistant program reimbursements. So that is more in alignment.
Thank you for making those edits based on Ralph's comment.
Yeah. John, raise your hand up.
Thank you. Thank you for the edits. I would like to make a motion for policy recommendation number 8 with the edits as applied. With board to approve policy recommendation 8 as amended by the board today to be included in the annual report.
Do we have a second to that motion?
This is Board Member Kennedy. I would second.
Melissa, if you could please call roll.
Dan Hartung,
No.
Lori Hoagland,
Yes.
Robert Judge,
No.
Dan Kennedy,
Yes.
Chris Lehman,
No.
John Murray,
My apologies. Yes.
Vice Chair Amy Burns,
No.
Chair Shelley Bailey.
Yes.
The vote is 4-4 and the motion fails.
Melissa, thank you for facilitating that. In alignment with the feedback that Ralph provided related to, I think, item number 6, I would like to ask specifically anyone who voted no related to number 8, are there any additions or deletions from number 8 that would change your vote in any way? Dr. Lehman, you have the floor.
Chair Bailey, to Dr. Burns' earlier question, is there a way we can pull dispensing fees and talk about dispensing fees in its own recommendation, or does it have to be tied to the pass-through pricing? Is that something that's like inherent and pass-through in the mandating of the dispensing fee to be tied to the pass-through pricing?
From my personal perspective, anything that board members would like to make edits to, right? To make it something that might change how they vote, I would be personally open to.
Is there wording that you would propose, Dr. Burns? Like around the fees or the minimum?
Yeah, I mean, I don't have a problem with splitting the dispensing fee out and so that it aligns with the language there. That was what my feedback has been consistently on the recommendations for especially 8.
Just for clarification, Vice Chair Burns, you want this removed to its own section, so this would be number 9 then?
Yeah, I just again think that there's a lot packed into this, and to me, trying to address dispensing fees is, I know that there was some objection to the word actionable, but it does feel actionable and timely and could go a long way to addressing some of the issues that pharmacies are experiencing.
So the edits that you see on screen provides for your recommendations of moving it into its own section, and then
That would work for me. Is that what you were looking for, Dr. Lehman?
Yeah, I think that's something I could support, Chair Bailey or Dr. Burns. Yeah.
So just for clarification, and I see there's 2 hands raised. Essentially, Vice Chair Dr. Burns, the proposal could be essentially the first bullet only. Is that your intention of what you were referencing? I just want to make, I guess it.
So where Courtney moved the dispensing fee bullet down, that is what I was trying to express earlier.
have its own component.
Its own recommendation.
And Dr. Burns, just to clarify, that would be across all payers, not just the certain payers.
I mean, I think that if you wanted to really break it down, in my opinion, the caps definitely need to be addressed. But the dispensing fee system for pharmacies, the payment structure is not doesn't work very well. So I don't necessarily need to see it just be for caps. Like I would vote for this.
Across all payers.
Yeah, I would.
So why?
And then I don't know if we need to take out the ERISA piece that both Mr. Judge and Mr. Murray had commented on earlier, because we're not going to be able to mandate it to them.
To remove this one. That John, is this the one that you were saying we need to remove?
I'm not familiar.
Dr. Lightman. I think that
I'm looking over here and only heard it out of my ear. So this exchange-based health plans is the one that needs to be.
Maybe Robert's better to answer that than I am. If they're ERISA based and federally regulated, the state, I don't think, can influence them. Is that the terminology, Robert?
Yeah, that's correct.
Okay.
Yeah, you can't set a reimbursement that, trumps what the feds have through ERISA.
Right. Okay.
So, so I think you'd have to carve ERISA out of this.
Oh, wow, Mr. Judge, I just realized that you are 9 minutes past.
I know.
My sincere apologies.
Can I make a parting comment before I kind of pull forward? So 2 comments. And kind of thinking about what Dr. Burns was saying, I do believe that the issue is probably greatest in the state for our rural pharmacies, and providing a dispensing fee to them, a reimbursement package to them. There's some sense in that. When I think about pharmacies and what pharmacies are paid, there's 2 components to it. One is the ingredient reimbursement part, And the other is the dispensing fee, the professional services, which today is in some respects pretty laughable. But the two together are what pharmacies are being compensated on. So if we separate it as being suggested here, we're going to see a dispense fee go up and keep the status quo on the ingredient reimbursement, which has margin in it based upon whatever the acquisition cost is from the pharmacy and what they're reimbursed through the third-party payer agreement. So I think what you would be doing the board would be doing if we recommended this going forward is resulting in a pretty significant cost shift to every payer in the state. And that the fiscal will kill this. I don't think it's good policy. It's not addressing affordability.
Mr. Murray, your hand was raised next. And you're on mute.
I do support the effort that's being made on the dispensing fee. If nothing else, if we don't modify the base cost that is that's based on, then a dispensing fee would keep these pharmacies afloat. And I think needs to be all pharmacies. I applaud this and I'm supportive of it as long as it's all pharmacies and all plans excluding the exchange-based health insurance plans.
Mr. Murray, thank you for adding that. I'd also like to reference that there is documentation both on pharmacies that there is sometimes, there is margin sometimes on acquisition cost versus adjudicated claim amount, but there's also documentation of losses on adjudicated claim amount versus acquisition cost. So I would just like to lean into Robert's comment about where sometimes there is margin, there is also sometimes losses.
I can double down on that comment from experience. Thank you.
I see your hand up.
Yes, I would just like to, affirm what Chair Bailey has told. I have anecdotal evidence from a pharmacy friend of mine who has lost $27,000 on Ozempic prescriptions this year due to being reimbursed below cost. So there's not much margin, and in some cases they're below margin. So thank you.
And Robert, you want to wrap up and then?
Yeah, then I'm officially going to leave, but I want to vote on this. So
okay.
I just want to remind our board members that 2 years ago there was an attempt to do this in legislation, and go back and look at the fiscal. And you had counties and cities screaming mad. You had the public employee plans saying this will be a budget breaker when we live in a 3.4% world of price escalations. I think it sounds on the surface good, but beware of unintended consequences. And this is a recommendation without any data behind it.
I know that you need to go and you want to vote on this. So John, you have a couple comments and then we can go.
Yeah, actually, my comment would be that we have reports by this Oregon Secretary of State, 3-axis reports by the Oregon State Pharmacists Association about pharmacies being underwater on costs. The vote that was taken 2 years ago failed by 1 vote in the Senate. It passed unanimously or widely in the House in the state of Oregon. So there is, and I think there's momentum going into this legislative session as well. So I hope for changes. I would make a motion at this point then to motion for policy recommendation 9. If I could just see the wording down below, please. At least to address the issue of dispensing fee. The edit, though, that it be applied to all plans that are applicable or legal in the state of Oregon, CCOs, commercial health plans, however it was written above, to be inserted there. And I guess I would like to ask that it not be passed on in the form of higher co-payments to the patients. That would be my motion. So approve policy recommendation 9 as amended by the board today to be included in the annual report.
Do we have a second to that motion? Or Vice Chair Burns, we cannot hear you.
Sorry. I want, Courtney, you pulled the minimum reimbursement for all prescriptions.
I'm
This is
trying to
just supposed to be the dispensing. Thank you.
I'm still in the process of editing where he's trying to make a motion.
Totally. I'll second.
Thank you for that, Vice Chair Dr. Burns. Melissa, if you could please call the roll.
Dan Hartung,
Yeah, so I've struggled with this and thinking about how well it fits in the scope of our mission. And looking at kind of our founding legislation, you know, I think we're supposed to protect the residents of the state and also a variety of stakeholders from the high cost of prescription drugs. And so pharmacies are the main stakeholder in the healthcare system in terms of delivering prescription drugs. So I'll support this newly detailed policy recommendation on those grounds. Sorry for the discourse, but I'm thinking through in my mind.
thank you. Lori Hoagland,
Could you please read it in total? We've been jumping around, adding, and I'd just like to hear it all before I vote.
The statement says, all payers, including CCOs, commercial health plans, and PBMs operating within the state shall reimburse dispensing fees equal to or greater than the dispensing fee used in Oregon's medical assistance programs. And we just discussed those prices, which was $20.86 for 340B coverage. And then for less than for 40,000 claims a year, dispensing reimbursement fee of $16.87. Then the last sentence is this dispensing fee may be updated periodically based on the updated surveys or economic conditions.
There was also a mention for not to change the copays. Was that?
Yes, please. Yes, that was part of the motion. Me too.
All right, so this one as well.
Yeah.
It wouldn't say the pass-through pricing model, though. I mean, or maybe it should.
Right.
I don't know. This fee shouldn't affect the copay for patient.
Yeah, isn't that like the pass-through pricing?
Yeah, you would want to remove that, I believe. It would be the model shall not.
Yeah. There we go. Yeah.
All right, can everybody see that still? Does that make?
Mm-hmm.
Yes.
Is that what the board's wanting for that language? Okay.
I vote yes with that language.
thank you. Robert Judge,
No.
Dan Kennedy,
Yes.
Chris Lehman,
Yeah.
John Murray,
Yes.
Vice Chair Amy Burns,
Yes.
Chair Shelley Bailey.
Yes.
The motion passes.
Melissa, thank you for facilitating the role. Courtney, if you could help us move on next to, I guess now item number 10. Mr. Judge, I see your hand is raised. You have the floor.
I am having to leave now, so thank you for today's session and wish the board a happy holiday.
Thank you, Mr. Judge.
Thank you, Robert.
All right, so going on to number 10. And Chair, I did want to take a moment to identify that the time is getting up to the end of the meeting schedule. And we still have the annual report to look at. Can we extend the meeting by 20 minutes as we finish off these last two discussions and then vote on the affordability review? Because that report is due by the end of the month.
Yes, I would like to propose that we extend the meeting by 20 minutes.
All right, if that works for everybody, I will move on to number 10. So number 10 is regarding the Oregon Health Plan fee for service and CCO purchasing through a statewide purchasing group. This entails a statewide purchasing group. They currently are groups or programs that leverage the collective buying power of state agencies to secure better pricing and terms for goods and services. And these programs are designed to make procurements more effective and efficient and cost effective for state and local government entities. So just wanted to ensure the purchasing through a statewide purchasing group is applicable. And I think I saw Chair Bailey's hand go up first.
Yeah, thank you. Just in alignment with what Dr. Hartung asked for earlier related to context, the context related to what we now have identified as number 10 is from the Oregon Secretary of State report. So this was one of the recommendations that was pulled verbatim from that report. So if that helps provide any additional context for anyone here today, I'm hopeful that that is helpful.
Thank you, Chair Bailey. Vice Chair Burns, your hand up.
Yeah, I just want to point out this already exists and it's in statute. The Oregon Prescription Drug Program is a multi-state purchasing group that actually anybody in Oregon can join, including CCOs. So this is actually in existence.
All right, Vice Chair Burns. Is there any other comments or feedback? Chair Bailey?
So mine would just be more of a question, if Dr. Burns feels comfortable answering it. Dr. Burns, are you referencing that because there's already a statute for this, does that mean that every CCO is participating, or do they elect to participate?
Well, again, so anybody in the state of Oregon can participate. It's open to everyone, including CCOs. So yes, it's something that organizations can elect to do. And it's open to everyone. So.
That answers the question. I just wasn't sure if everyone elected to participate or not, but thank you for answering that.
I see Mr. Kennedy, your hand is up.
Yes, I'm trying to be better with my mute button today. So I guess this is not really a policy. We're not really asking for anything. It's more like a statement telling you what statewide purchasing groups are doing. Are we recommending that statewide purchase groups utilize collective buying power of state agencies? I guess I don't see a question here or a comment.
Ralph, did you want to cover this a little bit more since?
Sure. To Dr. Burns' point, there are in fact CCOs, I believe EOCCO, if not mistaken, and Robert has left us already, that do participate in that. So I think clarity would be necessary from the board whether they choose to advance this as a recommendation that programs or CCOs should be required to purchase. And again, that's not a statement of support or dissent. That's a kind of staff clarification of this, that it should, if this was to go forward, that would be the discussion as to whether this would be to recommend to the legislature that they require this of CCOs. Which I think was consistent with what which I believe is consistent with the SOS recommendation.
Mr. Moraes, your hand up.
Yeah, actually, and then in second thought, maybe I don't have a question. If they want to participate, I would assume that groups would, if it would be advantageous to them to save money for their plans and their patients. What would be the reason that we would want to encourage them to use the statewide purchasing group if they're already trying to, I would assume, buy smart already?
And I'm not aware of how to answer that question necessarily. This was a recommendation.
Courtney, I can help answer that, at least from my own perspective, Mr. Murray. I think a lot of buy-side decisions also have to do with capitated rates. So my intention related to pulling that language from the Secretary of State's report was, and I now in looking at it, I believe I could have wrote it better, but the intention was to make a recommendation to require CCOs to participate, to eliminate some of the incentives related to global budget and capitated rate impacts on affordability and access. That was my personal intention.
Thank you, Chair Bailey. Appreciate that clarification. I did want to recognize Lori's hand was up.
So thank you. It's helped me understand because I didn't understand the purpose and also what would be reasonable if we want to put it in our report. And I want to recommend that we use the word shall purchase through a statewide purchasing group so that it makes it a mandatory situation.
I'm trying to see where we want to put the word shall.
Perhaps just add the word utilize after shall.
Mhm.
And eliminate are.
All right, how's that look? Any other recommendations from board members? Thank you, Chair Bailey, for the edits.
Not to imply that we will have a motion, but Melissa, if you could please add the motion language to the screen, that might help us. Do we have a motion for policy recommendation 10? Mr. Kennedy?
Yes, I would move that we approve policy recommendation 10 as amended by the board today to include in the annual report.
Do we have a second? Mr. Murray, your hand is raised.
Yeah, I'll second it for the purpose of discussion and vote, please. Thank you.
Thank you. Melissa, can you please call roll?
Dan Hartung,
Yes.
Lori Hoagland,
Yes.
Robert Judge is not here. Dan Kennedy,
Yes.
Chris Lehman,
No.
John Murray,
Here, unmute John.
John Murray,
I'm sorry. Yes. Thank you.
Vice Chair Amy Burns,
No.
Chair Shelley Bailey.
Yes.
The vote is 5-2 and the motion passes.
Melissa, thank you for facilitating roll. Courtney, if you can help advance us through what is now number 11 related to the statewide PDL.
Yeah, so this last recommendation is for statewide preferred drug list or PDLs for Oregon health plans, also known as OHP, fee for services. They currently have uniform PDL for some classes. However, to use the most cost-effective medications and to reduce administrative burdens for providers, it is recommended to extend the current PDL for all classes of prescription drugs to be covered. So open the discussion to board members, and Vice Chair Burns, I see your hand up.
Yeah, I would think that this would cause unnecessary admin burden to the fee-for-service P&T and the work that goes into making sure that they have a PDL. PDL is actually in what would be considered in the industry an open formulary. So medications can be accessed that are outside of the preferred drug list. They do a really comprehensive review of classes, and in fact, in rule, it really explains like how they go about it and what classes that they need to review. They do a very extensive job in making sure that classes, all medication classes, including OTC agents, are included. And so I don't really think that this is necessary or that it would add anything to the current fee-for-service PDL.
Thank you, Vice Chair Burns. Chair Bailey, your hand up.
Yeah, the only thing to lean into, again, for Dr. Hartong's question about the onus of some of these concepts, this was pulled directly from the Oregon Secretary of State recommendations from 2023. The only other thing I would add to that is in those recommendations, they did reference disparity related to geographic location on related to some of the PDL related issues. So I just wanted to mention that to my colleagues here today.
Yeah, the PDL is the same for the entire state for fee-for-service, so it should be uniform.
Thank you for the clarification, Vice Chair. Dr. Burns.
All right. Is there any other discussion or a motion?
Melissa, if you could please add the language to the screen related to this in the event we have a motion, we'll have the language there. Dr. Hartung, I see your hand is raised.
Yeah, the recommendation seems strange because it says to reduce administrative burdens for providers. I don't understand. Is something missing? Has something was not pulled from the? I've heard arguments. I guess I'm getting at is I've heard arguments to like have a consistent PDL across both fee for service and CCOs. And I don't know. I just want to verify that that's not what this recommendation is embedded in this recommendation, because that would alleviate the administrative burdens on providers if there is one common PDL across the state. Because this doesn't, as Amy suggested, this doesn't really alleviate any burdens as written.
Dr. Hartung, I would just lean into referencing, I may have added the initial language that was submitted to staff, but I'm glad you mentioned that because my intention had always been for it to be for both fee-for-service and managed Medicaid. That may or may not change anything for anyone here today, but I'm glad that you referenced that. And for the record, I would want to make sure to mention that to staff.
And Vice Chair Burns, I see your hand up.
Yeah, so if that's the change that's going to be made, then I would say that this would have needed more discussion and that would have needed to be evident when it was posted several weeks ago, because that's a very different thing that you're suggesting.
And I hear you on that, so thank you for that.
Did the board want to take a minute to alter any of the language or just do the vote as is, as the language is currently? Chair Bailey.
Yeah, no problem. My may or may not change anything for anyone here today, but my proposed addition would be to make it for fee-for-service and managed Medicaid.
All right. Melissa, I'm gonna still screen to make edits on.
And I would say Vice Chair Dr. Burns, while they're making those edits, so you have the floor.
Oh, I was going to make the motion to have us vote on it as written.
Okay, so I guess procedurally, we could have two votes, possibly. A vote on it as written.
Or with the edits.
Yeah, can we have clarification from staff?
I think the inference of statewide is already suggestive that it would mean fee for service and managed care. So I would, to that point, I don't know that the and managed Medicaid is necessary, but if it comforts folks to do that, you certainly could take that as a vote prior to an up or down vote on this.
Okay, so then I guess I would like to just break it into two separate votes. One is the language because fee for service is listed as fee for service. Can we identify if there's anyone that wants to provide a motion related to specifically with fee for service in the language
So as is currently.
as is currently, if there's anyone that is inclined to make that motion.
I don't understand can you clarify?
Yeah, my intention was hearing what you were saying, and then also listening to Ralph and what I had intended with the language. I guess I was leaning into trying to have two separate votes on it. One on item 11, and then voting to have it with the implied with the term statewide, voting on it to have managed Medicaid specifically called out.
Well, I mean, if Ralph thinks that the statewide word means what you're intending here, then we can just vote on it as is.
I would note it's just a heading. Potentially, maybe you want to strike the FFS or fee for service part at the end, and or conceptually just workshop, if it's the will of the board to advance this, workshop this very briefly at that, to just include, however, to use the most cost-effective medications and to reduce. It is recommended to extend the current PDL for 2 coordinated care organizations for all classes of prescription drugs. And then move to a vote. Although recognizing that Lori and Dr. Burns both have their hand up as well.
So while Courtney's making those edits, it looks like, Courtney, we would still have fee for service on the first bullet that we might want to remove. But I think, Lori, I saw your hand up first. You have the floor.
So I apologize. I'm a little bit confused here. What I'm hearing from Amy is that this is already for all classes. And then I guess, Shelley, you're feeling like we need to add this to strengthen the use of the preferred Douglas. I'm just a little bit confused about what it is now and what we're aiming to accomplish.
I think the feedback we received from Ralph was that if the language as is would be a PDL across fee for service and managed Medicaid.
Right.
That's what we're voting on.
Yeah, and I would discourage you from striking the FFS there and simply adding CCO ladder. No. Strike that and please. OHP fee for service has a uniform preferred drug list for some classes. However, to use the most cost-effective medications and reduce administrative burden for providers, it is recommended to extend the current PDL for all classes to CCOs for coverage of prescription drugs. And then I would recognize Vice Chair Burns.
Yeah,
and
I would
move
just
us.
like to point out again that that's not what was posted and not what was written, and that's quite a big change for Medicaid if we're proposing that, and not one that we've discussed yet. So I would really encourage that we don't add that in.
Okay, then I respect
And I
that. And
I
respect
think,
the will of
Ralph,
the
that
board.
you're really adding the language here, so it's coming from you.
Okay, well, I will respectfully decline that. I would suggest that the word statewide in this conversation or construct of preferred drug list generally does mean across the country and across this field of being both fee for service and managed care programs. Again, I am not advocating or discouraging the passage or support or rejection of this recommendation. I will also note candidly that staff has had these out for a number of months and has solicited input from board members. And some of the input that we have heard today, we are hearing for the first time. Had we had opportunity to hear some of that input in our one-on-ones with the board, perhaps we would have been able to make these a little more substantial.
Dr. Hartung, your hand's up.
Yeah, so I mean, yeah, so I acknowledge that these have been with us for a while, and for whatever reason, when I read this, I kind of implicitly just recognized it as extending the PDL to the CCOs, but then after looking at it in meeting and actually reading the text of the words, because it says to reduce administrative burdens, I was like, well, that doesn't make sense if you interpret it any other way. So, I mean, I'd support adding the additional text that Ralph suggested, just to kind of clarify it. I think that is the intent of, in my initial reading, and the fact that it didn't register at the time. And then I actually looked at the Secretary of State recommendation. It's recommendation number 4, mandate a universal preferred drug list and require uniform step and prior authorization criteria across Medicaid coordinated care. So if we wanted to, we could just port over the exact text of the Secretary of State. To me, it makes sense. And I would support, moving forward. We've adjusted these other things whole cloth as well during the meeting. So I think that this is a reasonable adjustment as well.
Thank you, Dr. Hartung. Appreciate that. Is there any other, since you have that language in front of you, is there any other descriptive words you want to use for this, or does it kind of read the intent of it overall?
You could say, let me just see here. I mean, I think that's sufficient. Or maybe, I mean, that's sufficient to me. I think that gets across the main thrust.
And again, any other clarifications, if this was to be implemented at a state level through statute, would be also clarified more in detail in the rule. So these are just the recommendations, and the legislators will apply any additional information. Right.
Well, and Courtney, as you're searching for that information with Dr. Hartung, I do know Vice Chair Burns had her hand raised, so maybe we could give her the floor while we're pulling that language.
Yeah, I would just like to point out, yes, Ralph, I mean, we read it. I provided feedback. I did not read it the way that Dan did at all. So I think that this is quite a change, and that there's an entire stakeholder group that essentially will be, weren't aware of this. So to me, this is a really big change, and is fundamentally different than how it was written.
While Courtney's pulling that language, Mr. Kennedy, you have the floor.
Thank you, Chair Bailey. I have this really tremendous addition. Courtney, could you make CCOs plural, please?
Yeah.
Thank you.
And Chair Bailey, I'm sorry, you're wanting the SOS report pulled up.
I was trying to listen to what Dr. Hartung was referencing, and my understanding of what he was saying, it was to pull the language verbatim. Dr. Hartung, did I hear you accurately?
Yeah, I mean, that's one way you could do it, because the recommendation 4 is basically says mandate universal preferred drug list and require uniform step and prior authorization criteria for Medicaid coordinated care. And so the only thing that this doesn't have in it is basically saying adopt, you could say adopt the fee-for-service preferred drug list for all Medicaid CCO, require uniform step and prior authorization criteria across CCO, or something like that. You could wordsmith it. But I think this is the same, the spirit of it is in this text here that we already have written.
Okay, so with that said, would you, referencing the spirit of the language, is the language that's presented before us right now, language anyone here would be comfortable providing a motion on?
Do you want to, here, I'll put the motion up. Or Melissa, can you put the motion up, please? Is there any motion just to add the recommendation language by Dr. Hartung? All right, so the board wants to have more discussion on this then? I just want to be mindful of time because we did extend it already by 20 minutes and we still need to approve the affordability review. So, the annual report to have it submitted by then, but Dr. Hartung, I see you.
Well, I'll move to approve the policy recommendation number 10 as amended by the board today to include the annual report.
Do we have a second to that motion?
This is Board Member Kennedy. I will second.
Melissa, if you could please call roll.
We can't hear you. Nope, still can't hear you. Nope.
Courtney, are you able to help facilitate a roll call while Melissa works on her audio?
I apologize, I don't know the order specifically, but Dan Hartung.
Yes.
I think it's Dan Kennedy,
Yes.
Chris Lehman,
No.
John Murray,
Yes.
Robert is excused. Lori.
Yes.
Thank you. Vice Chair Burns,
No.
Chair Bailey.
Yes.
Vote is 5-2. Motion passes.
Courtney, thank you for facilitating that.
Thank you.
Courtney, onto the annual report. I know that you did provide that to us in advance for feedback. But if you would like to discuss that.
Yes, let me take the screen back. Again, this report has been sent to all board members starting at the end of November. I do appreciate the feedback and comments. Just high level, no substantial edits to the annual report. Just a high view, this is the requirement under our Senate Bill 844 to provide to the legislators and the price trends, the cost trends for the prescription drugs that were submitted to us from the Drug Price Transparency Program, identified those and the associated appendixes that detailed the price trending for various drugs that were reviewed. Also looked at the review process for the affordability review. Even though the review was stopped, it was stopped in the indication that we had gone below the 9 drugs additionally selected. So we did go back with new data and identified a new kind of cleaning process to ensure proper review of the drugs. Unfortunately, we won't have time to review those lists today, so we'll really dive into that next month. Anyways, the report identified the challenges, various improvements, especially through the phased development that has been implemented. And then the recommendations that we had a wonderful discussion on today will be applied into this report for the legislators to review. So with that, is there any discussion, comments, or additional questions about the annual review draft, that language in the draft report, before ask the board to provide a motion for approval?
And Courtney, I would like to ask, did anyone provide any written comments to you related to the draft report before this meeting?
Public comments or from board staff?
Oh, sorry, board staff, board members. I just want to make sure if they had provided written comments that
There was
we.
no direct written comments regarding any constructive feedback or anything like that. Basically just acknowledgement that the report looked acceptable to pass.
Okay, thank you for that clarifying information.
I guess if there's, okay, Dan Kennedy, you see your hand up?
Yes, I would move for approval of the report.
Wonderful, thanks, Dan. Is there a second? Lori, I see your hand.
I will second it.
Okay, Melissa, if you could please call roll.
Oh, I don't know if she has,
Okay, so Courtney, you did a great job doing it the first time. Do you mind helping us with roll call this time?
I do not. I will do it again. Apologies, I don't always remember the order, but Dr. Hartung,
Yes.
Chris Lehman,
Yes.
Lori Hogan,
Yes.
thank you. Dan Kennedy,
Yes.
John Murray,
Yes.
Vice Chair Burns,
Yes.
thank you. Chair Bailey,
Yes.
passes 7. And Robert Kennedy is excused, so.
Yep. For the record, Robert Judge is
Yeah,
excused.
sorry, Robert Judge is excused.
Perfect. Thank you for facilitating that, Courtney. So I would like to announce the next board meeting is January 15th, 2025 at 9 a.m. Pacific. Please note this is a new start time for board meetings, which is 30 minutes earlier than what we have been encountering in 2024. I would like to ask staff, do you have any announcements?
Chair Bailey, other than well wishes to everyone on the board, staff, and those that participated and watched today, have a happy holidays. Thank you.
Thank you. And with there being no further business before the board, all in favor of adjourning the meeting, please say yes.
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 Any opposed, please say no. All right. Again, our next meeting is January 15th at 9 a.m. and happy holidays.
Thank you.
Holidays.
Board.